Hi, I'm Dr. Alison Kole, sleep medicine specialist and bona fide chronic insomniac. Welcome to the Sleep is My Waking Passion podcast. My mission is to share with you what I've learned both from my personal journey with my struggles with sleep, as well as my extensive clinical experience having treated all sorts of patients with sleep disorders for well over a decade. I will be interviewing experts across the boundaries of medical specialties, giving you a big picture perspective on why sleep is so important for your health. Remember that knowledge is empowerment, and if applied correctly, it can help you biohack your way to a better night of sleep, just like I did. If this resonates with you, please follow me on Apple, Spotify, or your favorite podcast app. So for our next episode, I want to introduce to you a very dear friend of mine, Erica Kaufman. We both trained at Cedars-Sinai. We did residency together, so I've known her for years because we're getting up there now. We hate to admit that, but it's true. She is now a wife, she's a mom, and she is a board-certified infectious disease specialist. In fact, she is wearing 2 hats right now. So she actually is the director of the infectious disease department for the Franciscan Physician Network in Munster, Indiana. You gave me a tongue twister. Well, simultaneously, she is the health and sciences director for the American Medical Association. I mean, I don't know how she does it. So welcome, welcome Dr. Erica to this crazy podcast that I'm doing.
Thank you so much. I'm happy to be here.
I am so stoked that you were willing to do this with me. When I was thinking about sort of like what was interesting about this topic versus the first topic that I did, which was on food and sleep, what was interesting is when you look at really all the data for food and sleep, it's very sort of sporadic. There are very small trials, so it's really hard to draw any big conclusions. So it was almost like you're sort of playing a little bit in the pseudoscience realm. And then we switched topics, and I was like, well, let me think about sleep and our immune system, because it's one of those things that we go around and you'll like read it all over the internet. It'll be like, you really need to get sleep because it's better for your immune system. And we spout it off like it's fact, right? And so when I was like, well, do I really understand why it's good for the immune system? And then I realized I'm like, no, I kind of don't know that. And so I want to be a person who enlightens others and enlightens myself at the same time about why we should even care about this statement and why it is indeed really that there's data that supports it. And then I realized that when we were both sort of prepping for this interview, that I gave you a topic that's a little bit akin to like torture in med school. Like it's the opposite of the food. It's like there is so much literature out there. One of the articles that we looked at from 2019 had 605 references. I was like, I killed a tree printing this out because I'm old and I like to read things on paper. So thank you so much for participating in trying to discuss what is a very complex topic. Before we go into that, I do want to talk about a couple other things. One being that I think it's important to give a context of who we are. So obviously I describe myself as a sleep specialist, and that is what I am. Why am I talking to an infectious disease specialist? But there's really 2 reasons for that. One is not only am I a sleep specialist, but I also am trained in pulmonary and critical care ICU medicine. That's mostly when I interact with infectious disease. And we're talking about pulmonary issues and we're talking about super sick patients. That's usually when those interactions occur for me. It's a little bit less on the sleep side, though that can happen. What I want people to understand is that in medicine, there's a tendency to really silo specialists. Well, I have a pulmonary issue, so I'm just going to go to that doctor. And I have a cardiology issue, I'm going to go see that doctor. And I have an infection, I'm going to go see the ID specialist. But really, what I want people to understand is that medicine doesn't work unless we're all part of a team. And what is interesting about that environment is just like you would in non-medical environments, everybody has their strengths, right? So we kind of play off each other. And what I might not be good at, you might be really good at. And that's how I describe it. Like a pulmonary ICU physician is basically, to use a sports analogy, because I can't really think of anything else, we're like the quarterbacks, right? We got a team, we're getting the team together, we got a mission. Instead of a touchdown, we're trying to get that patient to the finish line. We're trying to get them out of the ICU, stabilize them, get them better, get them home, back to their families. And ID sort of like the brainiac special teams. Like I'd call you in when I got that septic patient and I'm like, listen, I've like checked the blood cultures and I've done this and I've done that. and I have no freaking idea what's wrong with this person, but I suspect an infection. I need a second set of brains to come in and say, gee, there's these new tests that you should be ordering, and your differential should be a little bit broader. Maybe we should use this antibiotic or this antiviral, and you didn't think of this. So you guys are really important, and you're probably one of the smartest in like the medical field, in my opinion. And so I had to bring you on board because I was reading all of this stuff and I'm like, I kind of don't understand all of this. I think that Eric would be way better explaining it than me. So thank you, thank you, thank you. The final point is essentially that a lot of what we're looking at is association. So there's a lot of study and there's a lot of research, but it's not like association equals causation. So we want you to kind of understand that that's how we even approach medicine in general, is that we have all this information and it could change with time. So bear with us because we're doing a lit review essentially in 2023, and it may look very different in 5 years. All right, so without further ado, when we look at sleep in the immune system, we talk about this like bi-directional relationship. That is what we describe in sort of the medical parlance. Would you be willing to tell me a little bit more about like what that exactly means, or tell our listeners what that means?
Yeah, of course. So I think if you take a step back and you say, what is the immune system, to look at that sort of broader context first, because we'll have to get into the weeds of the immune system a little bit as we go through this. You've heard throughout this pandemic, especially, that the immune system is complex. It's a complex system, and all of that is true. When you draw like the flow chart of the immune system, it sort of makes your eyes cross all of the arrows and different, cytokines and proteins and everything that get on there. And full disclosure, I'm not an immunologist, but as you point out, infectious disease and the immune system are sort of dearly linked together. So when we think about the immune system, the first thing that we have is sort of barriers, right? We have skin, which is a great barrier for infection. Anytime you get a cut, that's obviously a way that infection can get in. Mucous membranes like saliva, snot, those things help keep infection out. Stomach acid actually helps break down a lot of pathogens so that everything we ingest doesn't end up making us sick. So those are very non-specific and what we call barrier parts of the immune system. And then we have two sort of big sections, which is non-specific immunity, which is anything that I might bring in. We have random cells that are not particular for that germ that I've just inhaled, but it's going to grab it and it's going to take it to the cells that are more specific for that pathogen. So we have a bunch of non-specific cells, and then we have these very specific cells that you probably have heard of, antibodies and T cells, and that's sort of the more adaptive part of the immune system. And that's really where, as we'll talk about, we see a lot of the issues with sleep is in that very specific part of the immune system that needs to activate and really take over when we have a pathogen that's very problematic for us as humans. So when we talk about bidirectional, that means obviously in both ways. So sleep affects the immune system in a way that decreased sleep equals decrease in the immune system. In the same way, when the immune system is activated, that is when we are sick, it actually promotes sleep. And so we've all felt this, right? You get sick, you've got the sniffles, and you just want to lay on the couch. That's your body trying to rest and get sleep so that its immune system can increase and fight off the pathogen. So that's sort of that bidirectional, sleep affecting the immune system, but the immune system also promoting sleep.
So when I was reading up on this, it sounds like, especially it seems like that relationship is that much stronger with chronic sleep deprivation. So the longer you spend not really getting sufficient sleep or quality sleep, that sort of has the potential to do more damage to our ability to have a good, robust immune system. Can you talk about that a little?
Yeah, so most of the studies, the word chronic sort of begs the question of how long is chronic? 1 week, 1 year?
Mm-hmm.
Most of the studies are in that 3 to 6 months of chronic sleep deprivation. And the amount of hours that define deprivation also varies a little bit. Sometimes it's less than 5 hours, sometimes it's less than 7 hours. So in general, what I have read, and correct me if I'm wrong, generally speaking, more than 7 hours of sleep is considered mostly adequate. Less than 7 hours and definitely less than 6 hours is where we start to talk about sleep deprivation. And so when you have chronic sleep deprivation, so let's say greater than 3 months of less than 7 hours a night on average, you're going to start to see decreases in the immune system. So specifically, you're going to see a decrease in the ability of the T cells, which are our body's sort of presenting cells. They're the ones that sort of work in the middle zone. They get these pathogens from these non-specific cells, like from your nose or your mouth. They look at these pathogens and they say, hey, this is right. You're right, antigen presenting cell. This is not a good thing to have in our system. And then they activate really the immune system. So they're going to activate pathways of inflammation. They're going to activate antibodies if needed, and they're going to activate other T cells to turn into killer cells to actually start to fight off. So when you have impaired T cell activity, which is what you get with chronic sleep deprivation, all of a sudden your middle managers here that are supposed to be the ones to make those big decisions about whether to turn the immune system on or off, those guys aren't working very well anymore. And also similar to that cycle, we see an increase in inflammation. So the regulation of all of these inflammatory cells that are supposed to really only get turned on in times of high stress, they get turned on because of sleep deprivation. One thing that I found really interesting is that with sleep deprivation, it stimulates the sympathetic nervous system, that fight or flight response, and that increases blood pressure and it increases your heart rate, and it also increases all of these inflammatory cells. And those inflammatory cells, though, aren't necessary. And so now you've got chronic inflammation, which can lead to all sorts of problems with your blood vessels, with, perhaps cancer promotion, different things. That chronic deprivation really leads to a decrease in the immune system's ability to respond.
Thank you so much for that. That was so helpful. What I do want to also point out, just because we're going to get into the weeds a little bit with exactly what happens with sleep, is I just kind of want folks to understand from the sleep perspective some of the basic jargon when we talk about, what happens with sleep in the immune system. So what regulates our sleep basically, or what makes us want to sleep? Well, we have a couple of things. We have this thing that we call a homeostatic drive, which basically, in a nutshell, I look at it as our body, the longer we're awake, our bodies are naturally going to want us to start to go to sleep. So we call that accumulation of sleep debt. And then, interestingly enough, we actually have a little timekeeper in our brain called the suprachiasmatic nucleus. That's a very fancy word, but the bottom line is it's like a little tiny timekeeper, and there's things that influence it, specifically light. So that's why you hear a lot about the negative effects of light late at night. And most of us, not everyone, and there's conditions where it could be delayed or early, but generally speaking, we're all in sort of this like 24-hour kind of cycle, which is why it gets dark, we get tired, we want to go to bed, and then we start our day again. In terms of what you can expect for sort of natural sleep stages, we cluster everything into two main groups. We have our non-rapid eye movement sleep, and then we have rapid eye movement sleep. And I don't know how that classification came about. I think it's kind of based on the EEG findings, but they're very interesting that we cluster them that way because what happens during those particular stages also is kind of unique. So it's like you're marrying sort of what you see on EEG with behaviors and sort of like physiologically what happens in the body. So when we first fall asleep, we go into a very light stage of sleep, which is stage 1, non-REM. Then we go into stage 2 sleep. It has certain characteristics that we see on the brain waves that distinguish it. And then we go into what we call slow wave sleep, delta wave sleep. There's the big slow waves. That's our deep sleep. So that's stage 3. And then afterwards, we typically have a rapid eye movement period. And rapid eye movement's very different because instead of having these like really slow waves of sleep, this is where if you wake someone up during that stage, they often feel very groggy because it's a very deep stage of sleep. You then go into rapid eye movement sleep, which is when you look on an electroencephalogram, you're looking at the brain waves. It almost looks like you're awake, like you see all this activity. Our bodies are paralyzed during that stage, which is really interesting. And we will kind of touch base on that a little bit later when we talk about narcolepsy and infection. Essentially, rapid eye movement, one of the things about it and how it relates to our immune system, slow wave sleep is a lot more front loaded. So we tend to have more slow wave sleep in our sleep architecture. And then later on, we have more REM. So it kind of flip flops. So the longer you sleep, the more REM you typically have. and, more slow wave sleep in the beginning of the night. What's interesting about, if you get infection, what it can do to your sleep architecture is you have a lot more non-rapid eye movement sleep. And often what they describe, it's not universal, and there's some conflicting data here and there, but generally speaking, they talk about an increase in that slow wave or delta wave sleep. And it also, in non-rapid eye movement sleep, we happen to also do a lot of thermoregulation. So what that means is that we can do things to kind of modify our core body temperature. And in rapid eye movement sleep, we sort of lose that. And so what's interesting about it is, okay, well, if you're having a fever because you have infection, what's been postulated is perhaps it's you have more of that non-REM sleep as sort of a way for your immune system to be like, dude, I need to work here and I need that time. And I need you to allow me that time. So I'm going to give you a lot more slow wave sleep, and you're not going to have as much REM sleep because it's physiologically not as protective. So there's thoughts that it's sort of about adaptation, which I found really interesting when I was reading that. There's many different types of organisms, let's say, that cause infection. And we want to name a few and kind of talk about how they uniquely affect sleep, because not all organisms affect sleep the same way. So would you be able to kind of distinguish for the layperson here, what's a virus, what's a bacteria, what's a parasite, what all that means?
We definitely break up infections by pathogen, right? Because not only do pathogens act differently in the body, but it requires different types of medications to treat them. You're not going to give an antibiotic, which fights bacteria, for a viral infection. You need antifungals for a fungus, not for parasites. So it's important for us to know what the pathogen is that's causing the infection so that we can tailor our treatment accordingly. So all of these pathogens are obviously microscopic. We don't see them with the naked eye. Bacteria are interesting because they actually can live in homeostasis with us. They live on our skin, they live in our GI tract. You've heard of your microbiome. Those are bacteria and maybe a couple little yeast, but mostly bacteria that live in harmony with us and actually help promote digestion and good immune response and those types of things. So bacteria are little single cell organisms that live in the environment and on us and can obviously infect us. Viruses are also, most of these are just going to be single cell organisms, very rudimentary, very early in the evolutionary process. The difference in them is sort of where they live and how they maintain their life cycle. So viruses have to have some sort of host. Bacteria can live on surfaces. They can live on food, but viruses are really host to host. You get that from somebody sneezing on you. You can get that from maybe fecal oral transmission. Parasites and fungus are mostly environmental pathogens. So those are things that we'll pick up from perhaps water with poor sanitation efforts or standing rainwater that maybe has been left to sort of rot and have different sort of environmental influences to it that make it yummy to different pathogens. Yeast and fungus tend to live on decaying matter. So that's what we see in rotted trees, piles of dead leaves. Those kinds of things are where you might pick up a fungal infection. Depending on what the pathogen is and depending on you as the person, what your hobbies are perhaps, or where you live might put you at risk for different types of pathogens. So we know that different fungal infections, for example, live out in the desert Southwest versus the plush sort of Ohio River Valley area. So in infectious disease, we ask a lot of very personal questions of our patients. We ask them what they do for a living. We ask them where they live. We ask them what their hobbies are. I want to know if you go hiking or if you go skydiving or if you go swimming. All can give me clues as to what might be causing the infection that you have.
See, I told you, these people are like monkey geniuses when it comes to all that level of detail. It is amazing.
I just think we're super nosy. We are just the nosy kid that we're what can we do? We could be a detective or we could be an infectious disease doctor. We're just going to get in there and figure it out.
Oh, I love that. Yeah. Hooray for the detectives of the medicine world. I think you have some specific expertise in HIV, if I'm not mistaken. So I really want to kind of talk to you about just kind of remind people, a lot of people have heard of what HIV is, but it's still something, if you think about it, it's like in our lifetime, like the OG of pandemics. And it's easy to forget that, but it's our version of the pandemic. So do you want to elaborate a little bit on that?
Yeah, absolutely. I mean, HIV is why I got into infectious disease to start with. Besides being a nosy kid, I also have a very large sense of empathy. And when we were growing up in the 80s, the HIV pandemic was really coming out. And I don't know about you, but I remember going to school and sitting through auditorium, speeches about how HIV was and wasn't spread, how it was okay to use a water fountain or a toilet with people that might have HIV, how you couldn't get it from a mosquito bite. I mean, you talk about the OG of pandemics, it was the OG of misinformation as well. A lot of myths and stigma and just lies spread, some of it from a bad place, really.
Amen. I know.
When you look at the first group of people that were really hit hard by the HIV pandemic was men who have sex with men, people who use IV drugs, and then hemophiliacs who got a lot of blood transfusions. And so those were the groups that were really hit hard. The reason I got interested in it because I was in Indiana and there was a boy named Ryan White that most people have probably heard of. And he was a hemophiliac and he was a few years older than us and he got HIV from blood transfusions. And he lived in Indiana, a rural town called Kokomo, and it was really difficult for him. He wanted to go to school, he wanted to be a normal kid, and they wouldn't let him. And when his mom fought and got him in school, he was harassed, he was bullied, rocks thrown through windows. I mean, things set on fire in their yard. It was really ugly. And I thought to myself, here's this person who has an infection and is just trying to live a life, and these people won't let him. And I just my heart broke for him and just for that whole group of people that were going through that. And for me, that was what got me interested in the field of infectious disease.
When people are diagnosed with HIV, do any of them really complain? It was interesting because when I was looking through trying to see, I thought it was very interesting because HIV does affect the immune system so profoundly. They talk about, okay, well, one study is, stage 2 sleep increases and you may have increased slow wave sleep. But then on the flip side, they'll say, okay, well, people wake up a lot more and they may have difficulty sleeping. And there's something to do with you being, even when you're asymptomatic and infected, like you're not having symptoms right now, that you can start to see these changes. Was that something that you would notice with your patients or something that they commonly complained about? Does that resonate clinically?
Yes, I would say more so with people who are in the later stages of HIV. You can be asymptomatic and have your immune system in the toilet, and that would be considered a later stage. So we look at HIV in terms of how badly damaged is the immune system. The definition of AIDS is somebody with a CD4 count less than 200, which is a really poor and low immune response. But you can be asymptomatic. I mean, as far as, you're not getting a lot of infections, you're sort of making it through the day. Like we have people that are just diagnosed with HIV and a CD4 count of 20 just because they decided to get tested that day, not because they're particularly feeling ill. But when you talk to people and their immune system is that low, they start to realize that there really were symptoms that they've been ignoring. Fatigue is by far the most common things that they complain about. They just can't get through the day like they used to, that they find themselves having daytime sleepiness because for some reason they feel like they're not sleeping well or they're not sleeping enough. I haven't had anybody complain of frank insomnia or poor sleep per se, but they are universally tired.
You could actually have something called a cyclic alternating pattern on your EEG when we look at brain waves. When I was reading up on it, it's not something we really discussed a whole lot of in fellowship. It's something that's mentioned sort of more in the neurology literature. But it basically means that your brain waves sort of change very frequently, and it happens in non-rapid eye movement sleep. And it's a marker of sleep instability. So it's often associated with poor sleep quality. So it's interesting because it's not that you can't sleep. It's more that you are sleeping, so you're sort of unconscious. You don't know what's going on, but your sleep quality may be silently kind of messed up with HIV.
Yeah, and that would explain why they feel tired but don't complain of sleep problems because they feel like they are sleeping at night. They're getting their 8 hours, but they're still tired during the day. So that would make sense.
I'm sure the fatigue is multifactorial, but it's possible that that could be a component too. I thought this would be kind of crazy, but what are your thoughts about discussing something that we thought was gone, but actually may not be gone? The polio virus. It's not eradicated. They had listed, and now there's been a few cases. We're going to get into the weeds a little bit.
It's so sad because it was gone, and the low vaccination rates have really, which is, I think there's a few reasons for low vaccination rates. During the pandemic, a lot of people didn't go to the pediatrician to get their regular vaccines because pediatricians' offices weren't open. We didn't know how to do that safely. So a lot of kids are behind, even though their parents are very well-meaning and well-intentioned to get them caught up. So that, I think, will help getting those kids caught up. But there's also a growing number of people who are not interested in vaccination. Polio is one of those viruses that for most people, like with most infections, you get it, you get through it, and you're fine. The problem is that there's a small percentage of people, maybe 1 in 100, that are going to have really severe, what we call the poliomyelitis, where they have the brain inflammation or the spinal cord inflammation, and that's really where you get the paralysis and sometimes even death. If that diaphragm muscle gets paralyzed, how are you supposed to breathe? You can't. Poliovirus has been found more in wastewater testing. So the CDC, test wastewater throughout the country just to look for where are we seeing measles or where might we be seeing polio, and then they can sort of watch those areas to make sure that we're not also seeing a corresponding uptick in human symptomatic infections. And so polio, unfortunately, is one of those that they're finding more and more in U.S. wastewater.
Yeah, I wanted to add, just in terms of the sleep piece, that in addition to the respiratory failure issue, which really is a diaphragmatic it's basically muscle weakness, right? Our diaphragms are huge. They're these big domes, and this is how we breathe. This is my wheelhouse, right? The breathing part. It's very difficult because if your diaphragms don't work, then you can't move your lungs in and out. And for folks that are uninitiated as to what the lungs do, they kind of function in two basic ways. Like, we need oxygen to live. So we breathe in and we absorb the oxygen. But the flip side is it actually helps us manage the byproducts of our metabolism. So it helps us excrete CO2. So we do it in the kidneys and we also do it in the lungs. We call that ventilation. So if you can't move your lungs all that much, yes, your oxygenation can be affected, but perhaps one of the first signs is going to be that you're not able to expel the carbon dioxide properly. And that's kind of what we refer to as a form of respiratory failure. And in my neck of the woods, if someone had muscle weakness, then what we would do is we would try to manage them with a machine that can help to kind of push the air in, what we call positive airway pressure, to help them try to ventilate a bit better. What is interesting when we talk about the brain inflammation associated with polio is that it affects the brain stem, which is sort of like in the back of the brain. In the brain stem, there's like the medulla oblongata, which I always thought was the coolest name in med school. And then there's the pons. And these are areas of the brain that kind of help us. They're sort of our respiratory control centers. And we do see an increased risk of patients who have had polio and they develop what we call a post-polio syndrome, sort of a longer term result, what you were mentioning about what can happen just if you're not able to clear the infection. And essentially, these folks, they develop what we call central sleep apnea. So most of the time when you hear the media, they're talking about a different kind of sleep apnea. This is really sort of that these parts of the brain get damaged. It causes these pauses in breathing that have nothing to do with your airway closing off. It's literally that they're not controlling things regularly. And so you have that pause. So that is something that is definitely unique. There's also some association with what we call leg movements. So it's been described that people will have these extra leg movements. I couldn't really find a whole lot of data about that, to be truthful. The term that we use for it in the sleep world is called periodic leg movements. And some people will notice it, other people won't. What we do with them kind of depends on how people perceive they're interfering with their sleep. Sometimes people do wake up and they said, oh, my legs keep kicking. It's a little bit different because you'll actually then restless legs per se. That's more of something that people describe as, oh, these are my symptoms and I have this uncontrollable urge and these other symptoms. They're a little bit different akin to that, but it's also something I can't say that I understand what it does other than if you're going to have neurologic inflammation, I would not be surprised that, just like in other sorts of disease processes that affect the brain, that you might have some movement issues that are particularly relevant during that time. Moving on to bacteria, I wanted to talk a bit about what your thoughts are about group A strep. When I read that, I thought it was so neat.
Group A strep is one of the more fascinating bacteria, I think, and super relevant, at least right now, because we've been seeing a huge uptick in invasive group A strep infections in kids and adolescents in the US right now. So group A strep, most people think of like, tonsillitis or pharyngitis, and it's annoying and it's uncomfortable, but most people don't think of it as being too big of a deal. The problem is that group A can also cause invasive infections, which can get to the kidneys, it can get to the skin and cause almost like a flesh-eating type of infection called necrotizing fasciitis, and that can be quite quick and rapid and can cause limb loss, actually, if not caught soon enough. So group A is not just a sore throat. It can really cause some damage, including heart valves. It's the reason why when kids have a fever and a sore throat, you should call the doctor just to make sure that this is not something that needs treatment, because without treatment, rarely it can progress to kidney complications, including renal failure. So group A strep can really hit the body and the immune system quite hard.
If you were looking to diagnose it, what are some of the things that you use? And I've read about this ASO titer and all of this stuff. What does that even mean?
Yeah, so the main way to diagnose strep, especially if you're talking about where it starts, which is typically in the throat, we do a swab, and we fortunately have a rapid strep test now that you can get back in, I believe, about 5 minutes in the doctor's office. And that's pretty good at telling positives and negatives. But we always also do a culture just to make sure that we didn't miss any on that rapid test. So that's the quickest and easiest way to diagnose a strep infection. You can get the more invasive infection. So if you have a really raging skin infection, or people can get it in their bloodstream, so we can culture whatever site we are most worried about, whether that's sputum, people cough up junk, whether it's from a wound, the pus that comes out, or just taking blood straight from a patient, putting it right on in a bottle to incubate and see if we can get strep that way. There is a blood test called an ASO, which is anti-streptolysin titer, and that is a test more to see if you might have had strep recently. So sometimes people come in and we might see that their kidney function is a little bit off, and they say, well, you know what, a month ago I did have a bad sore throat, but I didn't go to the doctor, it went away by itself. Checking that ASO titer might tell us, oh, if that's high, then that probably was strep infection, and this damage to the kidneys probably is related to strep, so let's go ahead and give the antibiotics now.
When they talk about human leukocyte antigen, can you elaborate on what that means? I have a basic understanding, and I'm happy to chime in, but I wanted to know if maybe you understood it better than me.
Well, HLA is sort of, human leukocyte antigens are basically markers of our own immune system to be able to say what antibodies have we been exposed to in the past, or has our body made just by virtue of us being us. My understanding, at least, is that they are sort of set, and similar to how type A blood people have to get type A blood if they need a blood transfusion, HLA is similar. We use that when we look at transplantation and making sure that somebody's kidney will fit into somebody else's system, is making sure that those matches are there.
So one of the things we know is that some people have different genes associated with different, HLA types. And I may not be saying this exactly correctly, so y'all have to bear with me. I'm not an immunologist. But there is one called the HLA DQB1. And for people that end up having this asterisk 0602 version, and not everyone does, I think it's estimated, split the difference and say it's around a quarter of Americans, and maybe less than that, but it's not the entire population. So it's sort of like the more minority of Americans or so that they see this across the population. folks with that type of HLA combination, if you will, or type, they might react differently to an infection like group A strep. And it's postulated there's an association between folks that have this specific HLA type and the development of a syndrome that's called narcolepsy. And for the patients or the folks out there that are listening to this podcast, narcolepsy is very interesting. It typically presents with people feeling crazy, exhausted, but not just like, I'm tired, doc, but I'm awake. I'm feel fatigued. That's the difference. These people literally can't keep their eyes open, like they're falling asleep. What's interesting about it is the way they made some of these associations is they looked at people and they looked at, folks that had narcolepsy and they match controlled them and they all had the same sort of HLA type. And they found a much higher incidence of folks having narcolepsy. It's often something that the onset of narcolepsy may be it's frequently like within the year of having that infection. So I find it very interesting that there could be this sort of genetic, they're thinking like maybe there's some autoimmune sort of process that is associated with it.
Does narcolepsy tend to run in families at all?
It can. It can. I don't think there's a hugely strong association from what I recall in my reading, but there's been clusters of folks in the family. They've never had genetic testing, but I actually had a young patient who didn't qualify for narcolepsy from the standpoint of how we define it as sleep doctors in terms of looking at an overnight sleep study, and then they take naps and we see what stages they go into. These people tend to really go into rapid eye movement sleep very quickly. She had what we call idiopathic hypersomnia, different entity for a different day. But what's interesting is she had a sister with narcolepsy. They both presented when they're pretty young. It's like, okay, well, is this really like a genetic thing? Or did both of them happen to be more susceptible to a type of infection? Strep is, people, if you've got little kids, they're share stuff and they could easily have both had strep at some point. You never know. What ends up happening is you get this infection. The thought is that you have this like autoimmune response. I don't think we understand exactly how that relationship happens from what I've read. And then there's a part of our brain, it's like deep in what we call our midbrain. And it's a portion of it called the lateral hypothalamus. And in that portion of the brain, we make this, what they call neuropeptide. Basically, it's a small, molecule. And it's called orexin. There's like orexin 1 and orexin 2. Some people know it as hypocretin. But the point being that these neurons, there's like these nerve cells that are supposed to make the substance. And it's very wake promoting. It's one of those substances that goes out and goes to other parts of the brain and says, hey, it's time to be awake now. And those areas get damaged. And they can actually see that there's a lack of this orexin, when they look at the brains of folks that have had narcolepsy. So it's sort of interesting how our genetics may play a role and how there's that fine balance. I mean, we're getting into the weeds of autoimmune disease, which I didn't intend to do, but I just think it's something I couldn't leave a discussion on infection without mentioning that some infections can trigger an immune response that may be sort of out of the control of what is the normal.
I mean, nowadays with long COVID, which is probably, again, another topic that is enormous, but one of the things that has really opened our eyes to in the medical community is the post-acute infection syndrome, or PAIS. And PAIS is similar to what you're talking about, where you get an infection and it's very general. There are so many things that have their own post-acute infection syndromes that, you could list them out on single-space paper and fill it. And there are a lot of them that produce a very fatiguing syndrome. Chronic fatigue, for example, is thought to probably have been triggered by some infection at some point, and then the immune system goes nuts for some reason or damages some part of the brain or body, and then fatigue just becomes really an unbearable sort of daily struggle for people. And a lot of that you are hearing with COVID, between the brain fog and the poor sleep and the fatigue. We know these people don't have COVID anymore. They're not still positive for the virus, but something from that infection has triggered some immune response. And I think, at least when I was growing up, we always just took it for granted that you were going to get sick. I mean, people get sick. What's the big deal? But I feel like now we're recognizing that, it is a big deal to get sick. And it's not just an inconvenience, and it's not just time off of school or time off of work, feeling bad for a couple of days. Like, I think we're starting to recognize that those insults really can have long-term consequences for people. And so little things like washing your hands, like not touching your face, like all of those things that we've been hearing about the last 3 years, I mean, those trying to keep yourself healthy, it really should be our priority. And that's, sleeping well at night as well, to get the immune system back up so that you can fight off things quicker and easier.
So I want to finish up because I know we're kind of running out of time. I almost thought about cutting it out because of time, but it's really interesting. And then more importantly, it highlights what a superb human you are that I can't not mention it. And that is a syndrome called HAT. It's a I can't pronounce it.
Trypanosomiasis.
Yeah, that. The reason I brought that one up is because it is actually something that I think is seen fairly frequently in Kenya. And you spent some time in Kenya, and then you formed Handle with Care. In our residency, when all of us are stressed out, you decide to literally form a charitable organization because you're both insane and brilliant at the same time. It's crazy. So I kind of wanted to have you talk a little bit about what you did in Handle with Care because it's so important for people to know that this is still an issue. And then maybe you could talk a little about HAT.
Yes, that sounds perfect. So as Alison had mentioned earlier, we went to residency together, and we might, you'll agree with me, have the best residency class in the world, maybe?
Yes.
Our group is just really still gets together regularly, and I am fortunate that I could not have done any of this without such a wonderful group of co-residents. But I did. I went to Kenya and worked there for about 4 or 5 weeks with the group actually out of Indiana University, and they have developed a very comprehensive HIV model called AMPATH, and that's how it started. And they've branched out into now acute medical hospitalizations. They do cancer care. I mean, they're doing open heart surgeries now. I mean, it has really revolutionized the sort of Western Kenya, which is very rural, medicine and medical care there. And so anyway, I was fortunate enough to be able to go and work there and really see the need for just dollars and support. And so came back and mentioned it to my co-residents, and they were all on board. And so we were too foolish and naive to realize that this was too much to handle, but we did it. So we did a fundraiser, and we had a young fashion student make a bunch of dresses, and we had a fashion show. We had music from a young musician playing, and we got a lot of donations, and we had a silent auction. And we were in Los Angeles, so we had a lot of movie memorabilia and signed things and just different, handmade jewelry from different people. And anyway, we raised about, even getting rid of the expenses that the hotel cost and everything, we raised about $30,000 to be able to send to this organization so that they could continue their life-saving care and provide HIV medications to the folks out there. And we did it again the next year, and that year we actually benefited one of the free clinics down on Skid Row that we would rotate through as residents. And that was really special because it still went to HIV care, it still went to helping, population in need, but it was a population that we all worked with and that we all were familiar with. Yeah, so that was really special. So thank you for giving me the opportunity to talk about it. It's I look at those pictures and I think back to, yes, how crazy, but how fun it was.
The energy of youth.
But yes, trypanosomiasis is super interesting. It is really found only in sub-Saharan Africa. This is a parasite infection. There's 2 different parasites in that realm of trypanosomiasis, and they sort of work a little bit differently. But the bottom line is that you get bit by this tsetse fly during the daytime, which is unusual because most mosquitoes and flies bite either early morning or dawn and dusk. But this one is very active during the day, which is how it gets to spread so much sickness. So wearing long sleeves and doing those things is really important. You get this ulceration a week or 2 after the bite, and then, a couple months later is when you get into the brain sort of portion of this, and it really disrupts the sleep-wake cycle, which I will let you talk about. But the bottom line is that there's no treatment, really effective treatment for it, besides going to the CDC and asking for perhaps a stockpile of experimental medications or things that they might be looking at as potential cures. There's also no test of cure. So you got to watch these people for like 2 years to make sure there's no relapses. So just like with all infections, prevention is the key. But it's very interesting the way that it causes that, like you were saying with other things, like polio can cause that inflammation and infection in the brain. And in this case, it just totally jacks up the sleep-wake cycle.
Yeah, it's really bizarre because, like I said, we have this circadian rhythm. So we have this natural tendency to sleep during the night and be awake during the day. And then when you lose that, these people are like sort of sleeping and then they're awake and then they're sleeping again. There's complete disjointedness to it. And when they've looked at it, they've even seen that people get, like, because they're not really having consolidated sleep, they have almost like these sleep onset REM periods, like you might see with a narcoleptic, for example, where they're falling into REM sleep very quickly, but it's really sort of like the result of the sleep deprivation. And there is some postulation that you actually, you have a lot of slow wave sleep. It's not very long. And then you wake up very quickly. So it's just this complete fragmentation of your sleep that, as you can imagine, would really diminish one's quality of life. And to be in a rural part of Africa and then be suffering from that as well. I mean, as somebody who definitely struggles with their sleep, I'm like, oh my God, that sounds terrible.
Oh yeah, because I mean, a lot of what they do in those rural areas involves a lot of walking, a lot of manual labor, a lot of creating fires and making things from scratch. And so there's a lot more sort of physical labor that is involved in sort of maintaining your life in that part of the world. This trypanosomiasis is called the African sleeping sickness because of that sleeping component being such a key part of it. And some people actually will go on to just be comatose. I mean, it can cause so much damage to those parts of the brain that it just sort of shuts off. And you're right, these people, they sort of just have an immediate urge to sleep. Like, there's no like, oh, I'm tired, let me go in an hour and lay down. Like, it is just like that narcoleptic, I must sleep now, even in the middle of the day. And to lose that circadian rhythm it doesn't seem like it would be so difficult, but it really does. It disrupts everything. And when you don't get that good quality of sleep, little naps probably don't get us back to where we need to be exactly as far as like the immune system health and total body health. And so it really is important to try to reestablish that circadian rhythm, get the melatonin back up when it needs to be up and down when it needs to be down. And it's a lot of regulation our body does that we don't even know to try to keep us in that homeostasis.
At the end of the day, what are Eric and I trying to say? One, if you don't sleep enough, it's kind of not good for your immune system. Infection really isn't a great thing. So if we can try to prevent it as much as possible and be our healthiest selves, right? We're all going to get colds and what have you, but let's have them be mild. Let's get through them. Let's have a good quality of life for a really long time. Good quality sleep helps you do that. And last but not least, if you are sick, don't try to be that like marathon warrior who's like, no, I'm sick, but I'm going to like work it out. Your body wants you to rest because your immune system wants you to rest. And they talk to each other. Our brains and our immune system are connected. So listen to what your body is telling you. It's going to be the better thing for you in terms of your health. If you really enjoyed what you were listening to, keep following us. You can follow us on Apple, Spotify, or your favorite podcast app. If you are interested personally in a sleep consultation with me, I am seeing patients in New Jersey and California via the sleep telemedicine program that I started with Oak Health Center based out of Laguna Hills. So check out our website. Thank you to Dr. Erica Kaufman, who is amazing, as you could see. And I know we had some like technical difficulties, but hopefully my buddy Joey is going to help me out. We'll piece it together. And you are super amazing for spending this much time and being so patient with all of this stuff. So thank you.
It was my pleasure. Happy to help. And as you know, education is one of my passions, and anything to get people understanding a little bit more about what's going on with their bodies is great.
I really hate to have to do this, but these are my terms and disclaimer. This podcast is intended for persons 18 years or older. This podcast provides general information and discussion about medicine, health, and related subjects. The words and other content provided in this podcast and in any linked videos and materials are not intended and should not be construed as medical advice. If the listener or any other person has a medical concern, he or she should consult with an appropriately licensed physician or other healthcare worker. The views expressed on this podcast and YouTube channel have no relation to those of any academic hospital practice or other institution with which the authors are affiliated. There is a detailed terms of use agreement. You can see it all on the YouTube channel. In the interest of brevity and the fact that it's legalese and really hard to read, I am not going to read it. But accessing, reading, or otherwise using the podcast or YouTube channel does not create a physician-patient relationship between you and me. Providing personal or medical information to me does not create a physician-patient relationship between you or me or any other contributors to this podcast. Nothing contained in the site is intended to establish a physician-patient relationship, to replace the services of a trained physician or healthcare professional, or otherwise to be a substitute for professional medical advice, diagnosis, or treatment. You hereby agree that you shall not make any medical or health-related decision based in whole or in part on anything contained in the site. You should not rely on any of the information contained in the site and related materials in making medical, health-related, or other decisions. You should consult a licensed physician or appropriately credentialed healthcare worker in your community in all matters relating to your health. You agree to indemnify and hold the author harmless from any claim or demand, including attorney's fees, made by any third party as a result of any content posted or made available to you by the site, any violation of law that occurs by you through the site, or anything you do using the site or the content contained therein. This entire disclaimer also applies to any guests or contributors to the podcast.